Thank you for joining this webinar. We'll give 1 to 2 minutes for others to join and we start. Okay, we will now start our webinar session. You are all welcome, ladies and gentlemen, to this session 2 of our IHR webinar. I would like to note that this is a joint webinar between the AFRO and AMRO, East Mediterranean WHO regional offices. And therefore, it reaches out to all the 54 countries in the African continent. I would like to thank the AMRO office for this collaboration. And we are very happy to host all of you. More are joining, and I think they will find us on the way as we do the opening remarks and all that. We started the session 2 weeks ago, and we had a brief overview of the IHR and IHR monitoring and evaluation framework and a few of the amendments. We got feedback and questions from many of the participants, and they indicated that they would like to know more. They'd like to have more detailed understanding of the IHR 2005 before they appreciate the amendments. So due to public demand, we decided that this session will provide more details on IHR and IHR monitoring and evaluation framework and the national focal point roles so that it can help participants to appreciate the amendments which we'll cover in the subsequent sessions. So I'd like to welcome you to this session, and without further ado, we'll move to the housekeeping remarks so that we know the modus operandi for our session. Over to you, Amarachi.
Good morning, good afternoon, colleagues. Thank you for joining us. My name is Amarachi. I am a training officer with the WHO African region, and I'm just going to quickly take you through a few housekeeping rules. As usual, the WHO events are guided by the highest ethical and professional standards, and all participants and panelists are expected to behave with integrity and mutual respect towards all. We have interpretation available in English and French. Um, Colleagues, can you move my slides back? Thank you. We have interpretation available in English and French. Colleagues, please look at the bottom of your screen. You would see a globe icon. Kindly click on it and you can access the language that you want to listen to the session in. Please use the Q&A for questions regarding the topic and presentations or the technical content that we're covering today. You can use the chat for general introductions like we're already doing, your name, your organization, and the country that you're joining us from. Questions regarding IT or logistics, if you're having issues with the interpretation or anything, our IT support is ready to jump in and help you. During the live Q&A, we want to encourage that colleagues take the opportunity to ask their questions to the panelists live. And if you want to take the floor, please use the raise hand feature. It's also at the bottom of your screen. And the moderator will give you access to speak, and we would also give you access from this end to be able to unmute your mic and speak. Next slide, colleagues. Great. By participating in this meeting, whether as participant or panelist, take your attendance as permission to record your contributions. And we will be sharing these recordings via our learning channels for continuous learning purposes. Now, the presentation, including the recordings, will be shared with everybody in the days following the webinar. Next slide. We had collected some registration questions from you before you joined the session. All of that data is with WHO and is kept confidential. We may be using those data, the data for report, for maps, for communication, but that would also be de-identified before use. Next slide. Today's session aims to provide the national authorities, this will be including the national IHR focal points of our member states, our WHO country offices, our colleagues from academia and the other stakeholders with an overview of the IHR 2005. And also, we will be updating you on the functions of the national focal point and the operational framework. Next slide. I'm just going to very quickly run through the agenda and then hand over to Dr. Miriam to introduce our distinguished panelists. We're going to have just 3 presentations so that we have enough time for the question and answer. And we're going to start with the overview of 2005, which will include the progress with the IHR implementation. Shortly after, we will then be having a presentation on the IHR monitoring and evaluation framework. And then we will do an overview of the IHR national focal points, and this will also include the functions and the operational framework. Over to you, Dr. Miriam, to introduce the panelists. Thank you, colleagues.
Okay, thank you very much, Amarachi. First, I will introduce myself. I'm Dr. Miriam, the moderator for this meeting, and I am a team lead for emergency preparedness at the Regional Emergency Hub in Nairobi. We are privileged to have special guests with us today. We have the team lead, IHR assessment, monitoring and evaluation of WHO EMRO, Dr. Amgad. He will be joining me to give the opening remarks. And we have one of our panelists, Dr. Ambrose Talisuna. He's Senior Health Advisor, WHO Liaison Office for AU and UNECA based in Addis Ababa. In his past life, he has also been a national focal point and also IHR advisor. So he'll bring with him a lot of experience. We have Dr. Mohammed from EMRO as well, and he's a technical officer in IHR and health security preparedness. So he does IHR as part of his day-to-day job, and he brings that his experience to us to share with us. As I said, the presentation, Dr. Ambrose will share with us a lot of knowledge about IHR national focal points, their functions and operational framework, including experience that he has. And then we'll have question and answer sessions. Please use this to ask as many questions as you would like. So now we'll start with the opening remarks. My team lead, Dr. Dick Chamler, is not able to be with us this morning to give the opening remarks. Maybe he will join us later in the session. And he has asked me to give brief remarks on his behalf, building on the remarks that he gave in the last session. Again, we welcome all of you to this meeting, thanking AFRO for collaboration in these sessions and all the national IHR authorities, the stakeholders, the partners that are joining this webinar. The international health regulations are very core to emergency preparedness and response, and therefore core to our work. They are designed to guide the global community on how to prevent and respond to public health threats that have potential to cross borders and a threat to global health security. They provide key principles and very important tools for international cooperation in public health. And this is particularly when it comes to the prevention of public health events like epidemics and pandemics, chemical spills, and even radiation events. And worth noting is that they are legally binding for all the 194 WHO member states that adopted them, and thus compel all of us to comply to the provisions therein. It is thus critical for all of us to understand what are these provisions that are in the IHR so that we know what is required of us. They have been revised over years, but now what is more in use is the IHR 2005. So you will hear us referring to IHR 2005 over and over again. We had COVID-19 pandemic that tested the IHR 2005 and its implementation. And it exposed some gaps and also opportunities for reform. And this is what prompted the IHR 2024 amendments that we'll be discussing in these and the upcoming sessions. So I encourage all of us to pay attention, ask questions to ensure that all is clear to you and that we are ready to move together in the implementation of IHR. I wish you all a fruitful webinar and hope that we will all learn something to take home with us. With that, I'll call upon my colleague from AFRO, Dr. Abdallah, to also give his opening remarks. Over to you, Dr. Amgad.
Thanks so much, Dr. Miriam, and thanks all colleagues from AFRO for facilitating and organizing such important webinar. Dear colleagues and all participants, as you know, and as Dr. Miriam highlighted, the IHR represents a crucial framework for safeguarding public health across borders, emphasizing the importance of preparedness, response, and collaboration. As you know, IHR played big role during different types of emergencies and different situations. But during COVID-19, which was the most recent big challenge we faced recently, a lot of lessons have been learned from such you can say challenge and also opportunity. One of those is it was highlight the importance of IHR as a legal binding to build the capacities all over the world. And based on the experience for COVID-19, number of amendment and number of modification have been added to the current IHR, which is, as Dr. Miriam highlighted, is usually referred as IHR 2005. During the coming hour and during this chain of webinars, we'll go through IHR details and the objective and how we can enhance the implementation of IHR. Implementation of IHR secure a baseline for protecting all of us. So all of us are the beneficiaries for IHR, either as individuals or communities, countries. I wish all of you a productive and useful webinars. I will not take long time for introduction, but I would like to thank all of you for participation, and please be more active, participated, asking questions, share your experience during such opportunity of sitting with other colleagues from different countries. Thanks again, and back to you, Dr. Mary.
Okay, thank you very much. Dr. Amgad, receive those that clapping, electronic clapping. So now, colleagues, will move to the technical sessions. We are calling upon Dr. Ambrose to give the first presentation, an overview of the IHR 2005, followed by Dr. Mohammed from the IHR monitoring and evaluation, and then Dr. Ambrose will give again the closing slides for this presentation. Dr. Ambrose, over to you.
Thank you very much, Dr. Miriam Nanyunja, for organizing this webinar series and for the introduction. I'm just going to, in the next couple of minutes, talk about an overview of the IHR monitoring and overview of the international health regulations. And then my colleague from AFRO will talk about the monitoring and evaluation framework. And then we'll go to a Q&A session, and then we'll do the IHR NFP later. Next slide, please. In this talk, I'm actually going to give a very brief context, and then I will define what global health security is. I'll look at the history and evolution of the international health regulations, and then an overview of the IHR 2005, a chronology of the IHR and how it came into force, and then we will enter into the IHR monitoring and evaluation framework. And finally, I will give you some snippets on the post-COVID WHO framework for health emergency preparedness, prevention, preparedness, and resilience, and then I'll sum up. Next slide, please. Now, in the current context, we are really in an interconnected world. Therefore, a health security risk anywhere in the world is a health security risk everywhere. You can move in a matter of time from one continent to another in just a matter of hours. And we saw this in COVID-19 and other cross-border infectious diseases like the Ebola virus disease, SARS in 2003. We've seen this for influenzas. We saw this for polio. We saw this for Zika. We saw it for MERS. They have raised the global awareness of the importance of global health security and the need for preparedness and emergency response, and ensuring that, just go back a bit, so wait a minute. Just go back, yeah. Ensuring global health security is a priority. And you know, our former DG Margaret Chan said, when the world is collectively at risk, defense becomes a shared responsibility of all nations. Next slide, please. So, what is global health security? And this is a definition from WHO. It's really the activities required, both proactively and reactively, to minimize vulnerability to any public health emergencies that endanger the collective health of populations across geographical regions and international boundaries. But health security becomes a general security issue and development concern when it threatens the nation's ability to function and safeguard its citizens' welfare, including the provision of basic services. And COVID-19 has showed this. So this new critical concern that the necessity to adopt a holistic approach to health, both from a health security approach controlling health emergencies, but also from a health development approach of tackling upstream causes and determinants. Next slide, please. Now, this is the evolution of the international health regulations as you know them. In 1951, the World Health Assembly had adopted what we call the International Sanitary Regulations. Then in 1969, we moved to what is actually the International Health Regulations. They were amended in 1973 and then 1981. And then we came to another revision today, the 2005 International Health Regulations, which were amended in 2014, 2022, and again 2024. So these amendments to the IHR are not new, and there has been some narrative of misinformation that, these amendments are trying to remove the sovereignty of a nation. It's a false narrative. Next slide, please. So this is what I've been saying, but just to put some more meat on this, 1951, International Sanitary Regulations. 1969, the IHR now were adopted by the World Health Assembly. They covered 6 diseases: cholera, plague, yellow fever, smallpox had not yet been eradicated, relapsing fever, and typhus. Those were amended in 1973 and again 1981. Because in 1980, the WHO declared smallpox over. So we couldn't continue notifying smallpox. And this was the time where we would say diseases for notification. So we remained with 3: cholera, yellow fever, and plague, because smallpox had been declared eradicated. In 1995, in consideration of international travel and trade and the emergence and re-emergence and spread of diseases, the World Health Assembly called for a substantial revision of the international health regulations. But this did not happen until when we got SARS in 2003. It catalyzed the formation of the Intergovernmental Working Group to negotiate the current IHR the way we know them. At that time, I was at the Ministry of Health in Uganda, and I represented Africa with Ghana and South Africa to negotiate the IHR on the international negotiating working group. So the IHR 2005 extended the scope of diseases and health-related events from diseases to consider all public health risks, be they biological, chemical, radiological, nuclear in origin, that might affect human, intentional, non-intentional. And they were adopted by the 58th World Health Assembly on the 28th May 2005, and they entered into force on the 15th of June 2007. They require states parties to notify potentially a wide range of events. And specifically really here, key implementation milestones are assessments of the IHR core capacities, which you'll be hearing from my colleague from AFRO, and development and implementation of plans of action to ensure that core capacities are available and functioning well. Next slide. So, this is the broad overview, the 3rd edition of the IHR, and it is structured. This is before the amendment. So it is structured into 10 parts. Part 1 deals with the definition. You really have to be speaking the same language. So what is the definition? What is a pandemic? What is IHR? What is a conveyor? So those Article 1 to 4 deals with definitions, purpose, scope, principles, and responsible authorities. And the key issue here is responsible authorities, which I'll come to in greater detail. Part 2 is about information and public health response. And this really issues around surveillance, issues around notification, issues around consultation, other reports, verification, and provision of information. So from 15 to 14, a very critical public response, including determination of a public health emergency of international concern, now including a pandemic emergency. And then Part 3 deals with the recommendation. These are really the recommendation following determination of a public health emergency of international concern. There are temporary recommendations and there are also standing recommendations. And then Part 4 deals with points of entry, the core capacities at points of entry, which is Articles 19 to 22. And then you have general provisions for issues like conveyances and special provisions for travelers, goods, containers, and loading. And then you have health documents, the health documents, and these have also been amended. So you really need to take this in part. And then the rest of the issues really are general provisions. And 9 deals with the IHR roster. We need a roster of experts. We need the IHR Emergency Review Committee and the Emergency Committee that helps the DG to determine a public health emergency of international concern and other review committees. And then the final provisions, and then we have the annexes. So that is really what we have now as the IHR. Next slide. Now, people have been talking, and this is a summary, and the next session will really be doing more details of these amendments. The amendments in 2024 were several, but some of them are just text, but it includes 27 of 66 existing articles now were amended with 3 new definitions under Article 1. 6 of 9 existing annexes were amended, and I will be really telling you some of the annexes that are so critical to member states. 2 new articles were added. But the key elements that we will go into detail into the next webinar are the issues around establishment of a national IHR authority, which is defined in Article 1, but is also now in Article 4, which is responsible authorities. And then the determination and definition of a pandemic emergency. You know that what we have in the current IHR is determination of a public health emergency of international concern. That's the highest sounding that we can have of a public health emergency. We didn't have a definition of a pandemic emergency, and that has been added. But you know that a pandemic emergency is, first of all, a public health emergency of international concern. And then there are issues around commitment to solidarity and equity, strengthening access to relevant health products, establishment of a states parties committee for implementation of IHR. This has not been there, so this should be meeting to assess implementation of the IHR, and then also coordinating and financing mechanisms, and then health documents, both non-digital and digital, and you'll see this in our future webinars. So now, this next slide, please. This is the International Health Regulation as we know it. What is it? It's the global health security framework to prevent. Previously, prepare for was not there. We have now added to prepare for, protect against, and provide a public response to all public health threats. And it's legally binding, like you heard from Miriam and colleagues from AFRO. And it was agreed to by 196 states parties, including 194 World Health Organization member states. The IHR uses the word states parties because non-member states can endorse. For example, the Vatican has endorsed the IHR and is a state party, but not a member state. There is a country in Europe called Liechtenstein. It has endorsed the IHR, but it's not a member state of WHO. So you could actually be, and you endorse the IHR without even being a member state. And that's why we use states parties and also member states, because if you're not a member state like the Vatican, we refer to you as a states party. Now, that is why we use those 2 nomenclatures in the IHR. And people sometimes ask, why don't we use member states? We use states parties. But it's a legal term for us to include non-member states that endorse the IHR. Next slide. So, the scope, which is the purpose and scope of Article 2, I've already really gone through this. It's commitment by states parties to collectively prevent, prepare, protect, and provide a public health response in ways that are commensurate with restricted public health risk and which avoid unnecessary interference with international traffic and trade. And then it requires the states parties, most of this time now really is really the member states, to establish and maintain core capacities to prevent, prepare for, detect, and respond. And those core capacities are stipulated in Annex 1 for the general surveillance, preparedness, and response, Annex 1A, and then for points of entry, Annex 1B. And the relevance of it is really that then countries then must put in place legislative mechanisms to domesticate this IHR. And this is really, you'll see when we come to some of the next issues of the IHR NFP. Next slide, please. So I want to articulate the issue around the principles. The implementation of the international health regulations should occur in full respect of the dignity, human rights, and fundamental freedoms of persons. And these have now been recently added and shall promote equity and solidarity. So it really, whether you are issuing measures at points of entry, bear in mind the dignity of human beings. Procedures must not be very invasive, and fundamental freedoms of persons. Next slide. Now, this is a timeline of when IHR, most of you have seen it. So they entered into force on June 2007. There was an initial assessment 2009. We thought would attain capacities around 2012. We extended that to 2014. Then Big Bang 2014 there. We had Ebola in West Africa, and we had to revise the IHR monitoring and evaluation framework. And you will be hearing about that shortly. But now we are going to extend this now because we have to show the amendments in 2024, so the chronology and when they will come into force sometime in September this year for some member states, but also sometime in March for others. Next slide, please. Next slide. So I want to focus a bit on what we call Article 4, which is responsible authorities. And this, I'll go to later to this because it's a critical piece in the amendment. We have what is supposed to be called a national IHR focal point, one per state party, one per country. So the national focal point is the center designated by each member state, which shall be accessible at all times for communication with WHO contacts person. So within WHO, at the region and headquarters we have, but the center, and there has been a misunderstanding about the IHR because people have been looking at IHR focal persons. You have a person in an office, but you are supposed to do all these verification, consultation, reports, notification. One individual cannot do this. And that's why when we're crafting the IHR focal point is a center. And so then you'll have the head of that center, then you have designate 1, designate 2, designate 3, designate 4. But it's not a person. It's a focal point, which is a center. And this has a bearing on some of the issues that we are going to be discussing later when we look at where it is supposed to be located. Next slide, please. At the moment, the IHR NFP has these 4 mandatory functions. One is notification of potential public health emergency of international concern and send urgent information. 2 is to remain accessible 24/7. So you can imagine, no individual can be accessible 24/7 because you fall sick, you travel. So that's why it has to be a center. And then disseminate information relevant for national sectors and then consolidate impact and input from all the other sectors. So this is really the current arrangement that we, next slide, as I try to
We have lost Ambrose briefly.
I think he is back, but he is muted from another camera.
Ambrose,
Hello?
yes. Okay,
Can
you're
you hear
back.
me now? Yeah?
Yes, we
I think
can.
I had a drop in internet. So this is the IHR operational framework. And Article 5 requires that you set up national surveillance response systems, including those at points of entry. So, and those are in Annex 1. And then that should help us to detect, assess, and report. And then the IHR NFP then has to communicate with WHO, disseminate information nationally, consolidating input. And then within WHO, we have the WHO IHR contact points. Now, if that information requires us to determine a public health emergency of international concern under Article 12, then the Director General of the organization will call the IHR Emergency Committee, and the IHR Emergency Committee then advises the Director General whether he should declare a public health emergency of international concern. And once a public health emergency of international concern is developed, is declared, then the DG issues temporary recommendations and standing recommendations that member states should implement to intervene or respond to the event. So that is the current structure. Next slide, please. My internet is dropping a bit, but I hope that I will. Now, what events should be notified under the IHR? And this is Annex 2. And I was on the expert committee that designed this Annex 2 in 2003, 2004 for the determination of notification. It's notification. It's not determination of a public health emergency of international concern, but notification. So 4 immediately notifiable conditions are in that box on the left. And these include smallpox. Smallpox, as I said, was eradicated, but the wild type has been kept in 2 places, in a CDC in Atlanta in the basement and somewhere in Russia. And because there have been arguments that like now for Mpox, you could generate new vaccines from smallpox. So that's why the live virus has been kept. There have been debates at the World Health Assembly as to whether to destroy it, but I can see that is somehow, sometimes we are now debating on that for the Mpox vaccines. And then polio. Previously, we had thought polio due to wild polio virus because the issue was the eradication of the wild polio virus. But we've seen vaccine-derived polio, and now Annex 2 has been amended. Now we have removed that wild type. Now it's any polio virus. And then human influenza caused by a new subtype, and then severe acute respiratory syndrome. And those boxes, so any event, then we ask using Annex 2, is the public health impact of the event serious? 2, is the event unusual or unexpected? And 3, is there any significant risk of international spread? And then finally, is there any significant risk of international, significant risk to international travel and trade restrictions? If the answer to those questions is more than 2, you should notify that event to WHO. Now, that notification is starting the consultative process. It doesn't mean that it's necessarily going to be declared a public health emergency of international concern, but it requires us now to start the negotiating, the consultative process, the verification process, getting more information on how the magnitude is to help the country or the member state to respond. Next slide, please. Now, I want to specifically talk about Article 43 because there are what we call additional measures under the IHR. Normally, when we declare a public health emergency of international concern, there are temporary recommendations and then standing recommendations. But member states under Article 43 can put additional measures, but those additional measures should not exceed the science and what is justified under the international health regulations. We've seen this happen. In 2018, for example, when South Africa had listeriosis, member states started rejecting meats from South Africa. We saw this in Ebola in West Africa, where restrictions to travel, and restrictions sometimes can even impact on how to deploy such teams, how to deploy logistics. We saw this in COVID with the new variant identified by Botswana and South Africa, and punitive measures were made. So Article 43 is supposed to deal with such scenarios, and that if the measures are not justified, the WHO DG can escalate this to national authorities to ask what is the justification for implementation on those measures. The only challenge with the current IHR, the way it is that the enforcement mechanisms is really for compliance is limited if a member state implements unjustified measures. And we hope that this will be cured in the pandemic agreement. But also there are some amendments now in Article 43 on how consultation will be initiated, and in the next session we'll be looking at that. I think this is the last slide, and I want to hand over now to my colleague from AFRO to present the IHR monitoring and evaluation framework. Over to you, colleague from AFRO.
So thank you, Ambrose, for that presentation, clearly and well done. So now we move to you, Dr. Mohammed, on the IHR monitoring and evaluation framework. Colleagues, please put your questions in the Q&A platform. Ambrose, I already see a question there for you to answer, and then we'll have minutes of discussion after. We hope that you can be also short and nice, Mohammed. Over to you.
Thank you. Thank you so much, Dr. Miriam, and thank you, Dr. Ambrose, for the very comprehensive part of the presentation. So if you allow me, I will continue on talking about the IHR monitoring and evaluation framework. We have 4 components of the IHR monitoring and evaluation framework. 2 components, we call them quantitative components, and 2 tools are qualitative tools. The quantitative components, they are used to assess the capacities through doing self-assessment facilitated in that discussion and structured site visits. We call them quantitative because we are putting scores quantifying the capacities in front of different indicators. While those 2 tools are the IHR State Party Annual Reporting, and the second, it is the Joint External Evaluation. While the 2 qualitative tools used to assess the functionalities that either it is an event that already happened, and here we are using what we call the action reviews, or we want to simulate an exercise or create an event, imaginary event, in order to test our capacities, and this is what we call the simulation exercise. Let's go to the first tool, the quantitative tool called the State Party Annual Reporting. So actually, according to the IHR Article 54, the state parties and the Director General should report to the World Health Assembly every year the implementation of these regulations as decided by the Health Assembly. So actually the results of the state party annual reporting, they are presented every year during the World Health Assembly, and that's why it is the only mandatory required tool among the 4 components of the IHR monitoring and evaluation. It is an annual self-assessment that is completed purely by the country without any intervention from any external partner. What we call the SPAR, it is developed by WHO. It started since 2010 to assess the state parties in fulfilling all these requirements. The tool is mainly based on scale scoring, as we mentioned, including 35 indicators and distributed among 15 technical areas, or what we call 15 core capacities. The form itself, it is submitted to WHO once filled by the team in the country, and it is stored in a secure database. We upload it on what we call the eSPAR, or the Electronic State Party Annual Reporting website. I think here we will just mention the list of 15 core capacities that we are reporting, or the countries are reporting every year in the SPAR. The first one, it is the policy, legal, and normative instruments to implement IHR. Second, it is the IHR coordination and national IHR focal point. Third, we have the financing, we have the laboratory, we have the surveillance, we have the human resources, we have the health emergency management. And then we have the health service provision, the IPC, the risk communication and community engagement, the points of entry and border health, zoonotic diseases, the food safety, and then we have both the chemical events and the radiation emergencies. And here, this is just a remark that was already mentioned by Dr. Ambrosi, that previously, up to IHR 2005, we had the national IHR focal point who was responsible to support the filling of this state party annual reporting. Now, with the amendments of 2024, we created what we call the National IHR Authority. The second tool, it is the joint external evaluation. And actually this tool and the next two tools, they were all coming with the resolution of the World Health Assembly 68, the resolution WHA 68.5, which was in May 2015, to have a self-evaluation should be combined by a voluntary review or voluntary external evaluation involving a combination of domestic and independent experts in order to avoid any bias by filling the SPAR without any intervention from external experts. That's why this tool and the next two, they are voluntary. So the only mandatory tool was the SPAR. The GEE, what we call GEE, it's voluntary. It is a collaborative multi-sectoral process which aims to evaluate the IHR core capacity implementation. It is conducted upon an official request coming from the member state. It includes 19 technical areas, so the 15 core capacities that the country is reporting to in the SPAR, plus 4 more technical areas. WHO usually recommends that we have the GE or renewed every 3 to 5 years. It is mainly, the process is composed of 2 parts. The first part, it is the country self-evaluation, which is very similar to the workshop done for filling the SPAR. And then the second part, and the most important, it is the external evaluation part done by the external experts. And then the final report is publicly available. There are 12 basic premises guiding the GE process. The first one, as we mentioned, it is completely voluntary from the member state. Second, it is a multi-sectoral evaluation. It is not an audit or inspection, and this is very important to notice. We are not here to blame anyone. Everyone just need to know the gap that he or she has in the technical area they are covering. It is based on a peer-to-peer review. It's based on openness, transparency, including publishing the report, as we mentioned. And because of the inherent characteristic of the GE tool, any direct comparison between the scores, solely just the scores between countries, it is not really valid. The key outcome are the 3 to 5 priority actions that is put under every technical area, which are the recommendations that came out at the end of the GE. It is a very collaborative process. It is in-depth review of IHR competences, and the GE tool and process have a broad global support. The GE final report has a very high visibility, and everyone, especially for resource mobilization, including recently what everyone is working on, the proposals of the pandemic fund, they are all looking to the results of the GE, and it's part of a wider global process to improve the global health security. Quickly, we will go through the 19 technical areas just to have an idea. The 19 technical areas are divided into 4 major groups. The first group is the prevention group or prevent. We have 8 technical areas under prevent, including the legal instruments, the financing, the IHR coordination, IHR focal point functions and advocacy, antimicrobial resistance, zoonotic diseases, food safety, biosecurity, and immunization. While the second group, it is the detect group. We have 3 technical areas under detect, including the national laboratory system, surveillance, human resources. Then we have the third group, which is respond. We have 5 technical areas under respond, including the health emergency management, linking public health and security authorities, health service provision, infection prevention and control, and risk communication and community engagement. While the last group, which is the IHR and POEs, it includes the point of entry and border health, chemical events, and radiation emergencies. If we move to the third component of the IHR monitoring and evaluation framework, it is the simulation exercise. And the simulation exercise, it's one of the qualitative tools that we are using. It is voluntary and it focuses on testing the functionality. So as we mentioned, it is an evaluation of a non-real event. So we are pretending that there is an event happening in order to test the functionalities of our different plans or different SOPs. It helped to develop, assess, and test functional capabilities of emergency system, procedures, mechanisms that respond to outbreaks and public health emergencies. And here it's important to know that we have 2 types of simulation exercise: discussion-based simulation exercise and operational-based simulation exercise. Example of discussion-based, it can be the tabletop exercise, which is facilitated discussion of an emergency situation. Usually it is informal and it have a very low stress environment. Other examples of the operational, we have the drill, we have the functional exercise, we have the field full scale exercise. If we take the example of a drill, it is usually a coordinated and supervised exercise activity that is normally used to test a single specific operation or function that we are testing in a repeated mechanism. While functional exercise, it's fully simulated interactive exercise that tests the capability or the capacity of an organization or an entity to respond to a simulated event. So those are the types of the simulation exercise. There are 3 main purposes to conduct a simulation exercise. First, it's to validation. So to validate the plans, the policies, procedures, or the system functionality. Second, the training to develop staff competences and give them practice in carrying out their roles. Third, testing is to test and evaluate plans and procedures, including the standard operating procedures. If we come to the after action review, this is the 4th component of the IHR monitoring and evaluation. It is also qualitative, the same as the simulation exercise. It is testing the functionality of a real event that already happened. And it helps to respond to an emergency as a mean of identifying best practices, gaps, and lessons learned. Usually we ask ourselves 3 major questions. What happened during the what existed before the response, what happened during the response, what well, what didn't go well, which help us to have a better response during the next time. It is voluntary, as we mentioned, it is a real event. If we come to the after action review itself, it's better to do it within a period of 3 months after that the event happens, so we can keep the good memory of the people who participated in the response. So it's involve all people who responded to the event, and it can cover infectious disease, it can cover chemical, radiological related hazards, food safety events, as well as natural disasters and man-made disasters. we have major principles for after-action review. It is participative, it is open and honest spirit, space for experience sharing and mutual learning, analysis of systems and processes, and oriented toward the identification of solutions, and a compilation of participant perceptions. There are four types of after-action review. The first type, it is the debrief. Debrief, it is the simplest type of after-action review. It is a facilitator-led discussion. Usually, it doesn't take more than half a day or few hours because it usually includes a very small group covering a small event. While the second type, it is the working group. Working group after action review, it is usually interactive, structured methodology based on group exercise. It is a plenary discussion open for a group of people and interactive. Usually each group, it has 6 to 12 persons and usually it takes 2.5 days to 3 days of discussion over a major event that happened. The third type of after-action review, it is the key informant interview, and it consists like of a longer and more in-depth review. It includes like research into the background materials and such as a peer-reviewed literature, any media reports or gray literature that came out. It's usually focusing on the key persons that maybe they are not able to attend the working group for different reasons. Maybe they traveled, maybe they left their positions, or maybe it's not easy to reach them physically. So also calls can happen with this key informant interview. It can be through online calls. And the last type, it is the mixed method. And the mixed method of the after action review, I think I lost the control. Remove, okay. Okay, now it's back. So the mixed method, it is a mix of the three types of the brief, working group, or key informant interview depending on the situation itself. Then during the response to COVID-19, it came out the interaction review. The interaction review, because it is an event that we don't really know when exactly it will end. So we don't need to wait until the end of the event that may take months or years. So we choose a specific period during the response to this event. And for this period, we do the interaction review, which is the same idea of after action review, but during the event itself. So that's why it is also a qualitative review of actions undertaken so far during the response to an ongoing emergency that doesn't end yet. In order to
Mohammed,
identify,
please summarize here.
yeah, sure. I have only 2 more slides.
Yes.
Gaps and lessons and best practices. So we can see that all these components of IHR monitoring and evaluation framework, plus other tools, including the One Health National Bridging Workshop, the strategic toolkit for assessing risks, the STAR tool, and so on, they are all feeding with their recommendations and outcome to develop what we call the National Action Plan for Health Security, which is a country-owned multi-year plan process to accelerate the implementation of IHR core capacities, and it is based on the One Health and whole of government approach. I think this was my last slide. Thank you so much. I would like also to thank the team here in EMRO, our team lead, Dr. Amjad, my colleague, Dr. Mahjoub, and my colleague, Dr. Fatma, for all the support during the presentation. Thank you so much, and over to you, Dr. May.
Thank you, Mohammed. Lastly, Ambrose, conclude the session. And colleagues, we are soon starting in 2 minutes, a Q&A session. Please put up your hands if you want to ask a question. Over to you, Ambrose, to conclude.
Yeah, so thanks very much, Mohammed. Now, following the COVID-19 pandemic, so WHO has come up with a framework for previous slide, the previous slide. Somebody moved my slide without my knowledge. I don't know whether it was me. Can you go to the previous one, please? My mouse is playing games. Go to the previous one, please, Amarachi. I think I was going to go through that, but I can back it up in the interest of time, Miriam, because let me go through this because I've seen in the chat box. IHR implementation requires a multi-sectoral approach. And we've really, because one single sector cannot prepare the world and one entity. So we all need to be in the room. And we've always used the language, the whole of government, the whole of society approach. So health security is everyone's business. We need resilient health systems. I mean, for example, continuity of essential services requires resilient health systems. We should be able to deliver health services during shock events, but also in the absence of a shock event. So we need resilient health systems. We need the health security core capacities and the national action plans and the pandemic and the health emergency preparedness resilience framework helps us to build those capacities. We need to work with the animal sector for zoonotic events, for food safety events. But even now, COVID showed us we need to work with the transport sector, we need to work with points of entry, we need to work with other sectors. Security, for example, we might require security, especially in fragile conflict and violence settings. In humanitarian settings, we need to work in humanitarian settings. Most infectious disease outbreaks actually are occurring in humanitarian settings. So we need to be looking at how do we incorporate health within humanitarian work, humanitarian response plans. The environment, of course, you know that interface, human, animal, and environmental interface, and the education sector. So, and I think this has a bearing on some of the issues that the amendments to the IHR we will be hearing, because where do you steward that competent authority in your country, which is supposed to implement the IHR? Because there is this whole multi-sectoral nature. So to conclude, really, one is we should institutionalize IHR monitoring and evaluation with overall sector performance. And now we are piloting the Universal Health Preparedness Review. After the pilot, if we think that it is working, we might add that to what my colleague Mohammed has presented. Final slide, please. Last slide, colleagues. So I would like to sum up like this. Despite countries' commitment to assess their IHR capacities, we saw this earlier, the West Africa Ebola outbreak and the COVID, they have unraveled major gaps. And without the required IHR core capacities, epidemics, pandemics, and other public health emergencies will continue to have a major consequences. They will continue. So we need to build IHR core capacities. We need to link that to resilient health systems. But finally, colleagues, we lose so many people due to preventable death from public health emergencies. Mm-hmm. And these people are just not statistics. They are real people. So the narrative around the IHR, that the IHR are going to remove sovereignty of member states, they are going to strengthen the sovereignty. I mean, you can't make a decision. The IHR doesn't take away the sovereignty of your member states. The World Health Assembly is the one that endorses the IHR. It's not the Secretariat. I've had a narrative that, we are leaving the mandate of the international health regulations to non-elected leaders. Our Director General is an elected leader. Our regional directors are elected leaders. The member states are the ones that endorse the IHR. We as the Secretariat, we help to implement. So really, we need to make this narrative go away. The IHR will make the world stronger. I thank you very much for your attention.
So thank you very much, Ambrose, and Mohammed for this. Colleagues, we'll have some minutes of Q&A. You can receive the hand claps. So we have some minute for Q&A. Please put up your hand and ask questions. Meanwhile, we can maybe try to have some questions answered publicly. Mohammed, there was some question for clarification on the method 4 of action after action review. That is the mixed method, I believe. Please explain a little more.
Thank you. Thank you so much for the question, and thank you, Dr. Miriam, and thanks for my colleague, Dr. Ambrosi. So actually, for the mixed method of the after-action review, this is when you cannot stick to one of the previous three methods, the debrief, the working group, or the key informant interview. For example, if we have 90% of the people who responded to an event, they are present, still available in the same place. So we'll do for them working group method. And then two of the major responders, they left the country and they traveled abroad. So we'll use with them the key informant interview. We will have an online session with them to ask them the needed question and get the information needed. So here we use the mixed method. So the report that we will develop for the after action review, it will include the outcome or the results of the working group that was organized for the people physically, and also the results or the outcome of the intervention that happened through the online session for the key informant interview. So here we call it the mixed method for the after action review. Over to you, Dr. Miri.
Thank you very much. We also, Ambrose, we had several questions on the national focal point, the constitution. Is it multi-sectoral? Is it individuals or people? Would you want to take it now or in the next presentation?
On the national focal point, I would like to take that in the next session. But I saw the question on what is unusual and unexpected. And I would like to clarify that the Annex 2 actually has a detail that defines each of those. For example, an unusual event is an event which is caused by an unknown agent or source or vehicle or route of transmission. So that, and then also the evolution of cases might be too much compared to normal cases. For example, in scenarios where you have some endemicity of those, but unexpected is really also defined as caused by a disease or agent that already has been eliminated, for example, smallpox, and eradicated, or by a new variant or something like that. So those are the kind of definitions. But again, when you go back to Annex 2, there are additional questions that help you to answer those questions. So it's really a question of going back to read Annex 2 and seeing for each of those events, you are given a few examples on what it constitutes. So I'll take the others because I still have one presentation on the NFP. Yes. Yeah.
Okay, thank you. There was a question, it was answered in the Q&A, but I think it would benefit the whole group. And it is a question on the difference between pandemic agreement and the amended IHR and the relationship between the two of them. Dr. Mary or Maju, you may want to just make your comments so that the whole team can appreciate them. Dr. Mary, supplemented by Maju. Is Dr. Mary still with us? Okay, Maju,
yes, thank you.
please
Until you hear from Dr. Mary, just in summary, the pandemic and revised international health regulation 2005 are complementary, but still they remain an independent legal instrument. The pandemic agreement addressed broader issues exposed during COVID-19, as per the several assessment and lessons learned from COVID-19, such as equity in inequity in access and countermeasures, technology transfer, and the governance issues that has been detected during the pandemic response. Over to you.
Okay, thank you. Pandemic agreement also covers things like pathogen access and benefit sharing, technology transfer, etc., to make sure that in times of pandemics, there's equity and solidarity and compliance so that all can access medical products as fast as possible. But when you read the two documents, they are linked and you'll find cross-reference, especially in the pandemic agreement, which was approved later, you'll find cross-reference to the amended IHR. We will come to a presentation, a brief one on the pandemic agreement later in our series. Over. I see still no hands up. Only 2 more minutes for final questions. We got feedback that people would like to interact by asking questions, but I see no hands up to ask questions. But at least I think by answering what is in the Q&A, you are getting a lot of your unclear issues clarified. Okay, thank you very much. Please continue to put the questions in the chat, in the Q&A, and we'll continue to respond. We'll move on to the next presentation, which is by Ambrose on the National Focal Point and Operations Framework. It is key that we understand this, and then we will see how it fits in now with the new recommended National IHR Authority. Over to you, Ambrose.
Thanks, Miriam. And this is going to be very brief because you'll have to move for me those slides because I think it's my mouse is edgy. I'll put it in slide presentation, please. So in the next 10 minutes or so, I'm going to talk about the IHR National Focal Point and overview of the NFP functions and operational framework. Next slide, please. So next slide, please. Keep that. Again, in a highly mobile and interdependent and interconnected world, it provides opportunities both for rapid spread of risk, but also for global preparedness and response. And this is really why the IHR is important and the importance of the IHR NFP. Next slide, please. So there are certain principles that, again, we talked about this, but to limit international spread of disease and other hazards, but also avoiding unnecessary interference with traffic and trade. And you saw that in those presentations that we made previously. So can you go next slide, please? And because I wanted to avoid certain things that people sometimes think that the international health regulations are a new program, or a new public health program, or a new science. It's not. It's actually supposed to help us. A collection of domestic and international best practices to strengthen relationships among sectors and improve day-to-day public sector capacities. And you can see among sectors there is a very critical piece. Next slide, please. Skip that. Go to the next, please. I went through this previously, and this is what is supposed to, when I was presenting, it's under Article 4 now, and this has been amended actually. So the IHR is, the national focal point, I went through this, is very important. So you can go to the next slide, because we went through this when I was making the earlier presentation. Can you move the slides, please? Now, I want to remind you again, this one, really again, coordination of multiple sectors to do those mandatory functions at the moment. And I presented this in the earlier presentation because I want to have Q&A. I want to move to the next slide, please. Next again. This one, this is really the critical framework. And you can see the articles that work within that IHR operational framework and the national NFP. Now, you are supposed to work with different sectors, ministries, animal health, environmental health, and compile the information and notify WHO. And you use all the other articles that are within the WHO. But once an event is then declared a public health emergency of international concern, or now a pandemic emergency, the DG then institutes temporary recommendations, which are under Articles 15 and 16. And we then start doing the response. So this is the current situation. The IHR NFP has mainly those 4 mandatory functions. Next slide. Again, this one we went through, so skip that one, please. Next. Now, the event management steps. So information can come in from initial screening, triage, informal, unofficial. In fact, event-based surveillance. It can be formal reports, integrated disease surveillance. So you have to put all this and do what we call event risk management, and manage the risk and then disseminate information. And there are other networks. At the country level, then there is supposed to be partnerships that then help us. But that is the framework for where are the sources of information. So the information then is used for you to do event risk management, assess the event, and then notify, initiate the notification. Next slide. So the decision, next slide, please. The decision can be at country level. Previous one, I wish I could build my slides. This one. Either there is no action, or there is a public health action which is domestic or international, or it is just information sharing. And those are the channels of information that you use. There is a whole notion about confidentiality of the information and the relevance of the information. Next slide. You skip this one, please. Go to the next one, please. Now, the IHR NFP functions as a conduit of information between national leaders and the global coordinators. It does not replace the existing bilateral and multilateral arrangements. It's a mechanism to supplement national state biosurveillance capacity, timely notification, new potential events and situations. The process also allows you, because once the notification takes place, then you can verify, you can validate rumors, and it helps increasing, refute them or not refute them. And at borders, at points of entry, it can allow for you to do community-to-community communication. Next slide. What are the benefits of having the IHR network? So if you have one state's party has a network, we want you to be linked to a network of NFPs, because then there is an efficient manner one country can communicate to other through the NFPs. You can communicate to the WHO contact points, but you can also communicate with each other. And you can access the event information site to look at what is happening globally, because you have a passcode. All the people in the IHR NFP national focal point can on passcode access the event management site. And so you can look at what is happening in the world. It's an effective, reliable system. So you have a readily available list of NFPs. Now, let's go to the next slide, please. When IHR was designed, there was a development of a toolkit for the implementation of the national focal point in the national IHR. So there is also the IHR guide, the IHR NFP guide on the establishment of the IHR NFP. But also, there were what were called additional functions. So the IHR at the moment was meant to implement 4 mandatory functions, but then the other additional functions were also supposed to be implemented. So next slide. So now I'm going to go through what we call additional, optional, or expanded functions, which could be done by the NFP, or the state party can decide who is going to implement that. There are a few slides that I have for this. So in addition to the four mandatory functions, these functions have to be conducted. Next slide. One of them is engaging in collaborative risk assessment with WHO regarding public health events. The second is disseminating information. If this expanded function is not done by the IHR NFP, then there must be a center that has to do it. Liaising with relevant authorities for points of entry under Articles 20 and 21. And also building core capacities. You can imagine who is going to implement the national action plans for health security. It's not a function of the NFP, but it is a priority function. Coordinating analysis of national public health events, coordinating emergency response. So you must have the Public Health Emergency Operations Center, which has to coordinate that. That is not necessarily an NFP function, it's an additional function. Next slide. Providing advice to senior health officials. Ensuring assessment of existing surveillance and response systems. So you have IDSR, you have whatever surveillance system. Who does that assessment? That's not, it's an additional function. It's important for the implementation of the IHR, but it's not an NFP function at the moment as a mandatory function. Next slide. Cooperating with WHO to provide interventions, facilitating surge teams. And again, I talked about implementation of. So these additional functions were in the IHR, they are supposed to be implemented. They are not a mandatory function of the IHR NFP, but they have to be implemented by some agency, some responsible authority. In most countries, there has been a Ministry of Health. Some have set up national public health institutes, but the multi-sectoral nature then of the IHR calls that we really need to rethink on how we are going to implement these functions. And now this brings me to the final, next slide. So there are major implications on the functionality of the IHR NFP in the new amendment. Under the Article 4, and I want to do this because this will now open for the next session when we do next week, each state party now will be required to designate or establish, in accordance with its law, one or two entities to serve as a national IHR authority and a national IHR focal point, as well as the other authorities. So the IHR focal point continues to do the functions that they are doing now, but you will be required to have, if it is separate, a national IHR authority that has to implement the IHR as a whole. Now, this has very implications because now the authority is the one to coordinate the implementation of the international health regulation. It's almost like to implement whatever was previously called additional, expanded, or optional functions. And you have to designate who the agency that is going to do that. It can be the same where the IHR focal point sits, they can be separate, but because of the multi-sectoral nature of the implementation of the IHR, this requires to be elevated. And that's really where I want to stop on this presentation, Miriam, because that has implications, and we shall go into detail now on where do you steward the IHR National Authority, and what is the linkage between the IHR National Authority and the current NFP in terms of implementing the IHR. So I thank you, and I can take some questions. The rest of the slides you'll read through as part of the additional material. Thanks, Miriam.
Okay, thank you very much, colleagues. We thank you for your attention. We have come to another Q&A session. If you have any questions, please put up your hand and ask the questions. In the meantime, as I wait for you to ask the questions, I will ask the team members to answer some of the questions live. There's an interesting question, Ambrose, which asks that why do we need the IHR authority when NFP is monitoring IHR implementation? Please let them understand why we need IHR authority at a higher level. I think Mary has gone. If she was
I think
here,
the issue here is if you look at what has been happening in most countries, in fact, the practice at the moment is that most IHR NFPs are a person. And most countries had not designated the center which is supposed to be responsible for those functions, even the current functions. So when we do the joint external evaluation, we assess where is the NFP, because you can see it is also in the state party annual report, core capacity, but it's also in the assessment of the joint external evaluation. We always ask where is the center, which is the NFP, and who does the expanded functions. Now, I think the recommendation from the working group for the amendment, the targeted amendments to the IHR, thought that at the moment, most IHR NFPs are very lowly located today to implement IHR. So there is a need to have a multi-sectoral platform that can implement. And so that's the recommendation that member states establish a national IHR authority to implement the IHR as a whole. This could be elevated and can also co-host the NFP. That is a choice that the member state can decide. But you could leave the current NFP function the way it is and designate another authority to work as the IHR authority. It could be a National Public Health Institute if that has been established. It could be a division established under different offices to reflect the multi-sectoral nature. But there is a guidance document, but this is a member state decision for you to decide either to have one or two and try to elevate the IHR national authority. Mary can add.
I think Mary is not with us. Mary is a WR of Eritrea. She was able to be with us briefly. I think she has gone out because of other duties. Oh, Mary is still logged in. Mary, can you hear us? Okay, but the key issue, as Ambrose has said, was trying to elevate the IHR national authority to a level of national importance where it can influence IHR implementation at a bigger level, including even the budget, the domestic budget, multi-sectoral coordination, etc., as we will hear in the presentation next week on the amendments. There is an interesting question here about complementary and alternative medicine. I don't know who among the facilitators would like to attempt this. It says that where does complementary and alternative medicine come in IHR, because the public is now seriously shifting to this during pandemics. As people are thinking about that question, I'll come back to you. The other one, in the light of the United States announced withdrawal from the WHO, does the country still share public health information with WHO under the IHR regulations? We can say that as a country that endorsed the IHR obligation of 2005, it's still obliged by the IHR. Whether it is complying or not is another issue, but it is still obliged by the IHR to collaborate with the other countries in sharing information and all that. I think I'll stop it at that. Colleague, please.
Yes, I think You're right,
Yes.
because the US endorsed the IHR in 2005. They participated in the amendments, in the negotiations with the amendments. I mean, I think it's still mandatory. As I said, they can, I mean, they have made the decision that they want to withdraw from being a member state of the WHO, but they could still remain a signatory as a state party, because
Yes.
you don't necessarily have to be a member state of the WHO to be a state party to the IHR, just like the Vatican and the other countries. So they can remain to endorse from that framework, because the IHR then helps them to get information. On the complementary medicine, I think this is there is the whole issue around access to relevant health products, which has been put in the amendments, which we will be dealing with. But it's if complementary medicine is found to work, I mean, the issue is really we have a whole issue trying to look at that complementary medicine, traditional medicine. I mean, because of desperation, people might use different approaches available, but we have a mechanism of going through approval processes for emergency use authorization of certain products. So if complementary medicine is documented to work, I think there are established mechanisms within WHO to make sure that those products can be used for pandemic response. But you know that the desperation in COVID-19 made people use things that we thought were not working, and we require that those go through some kind of scientific rigor to assess whether they work or not. Over.
Okay, Dr. Michael, I hope you are still on. There's a question if there's a monitoring mechanism to check the establishment of NFP and its 24-hour operation as a former national focal point in Ghana. Please, can you answer this question?
Thank you, Dr. Miriam. Yes, there is certainly a monitoring mechanism in place, and we go by the standard tools provided by the WHO to look at these MAE functions. And every year, the NFP, together with stakeholders, need to complete this tool and share with WHO and other relevant stakeholders as well. And so in terms of it being done, over the years, the NFP has fulfilled that mandatory function. That's for Ghana. As to how widely that information is circulated, maybe that's what we need to do, and also explain some of the findings, and more so improve on what has been found to be in existence for the good of the MAE, not just MAE, but making sure that the information is used to action. Thank you, and over.
Okay, thank you. Yes, to also note that WHO has been regularly holding meetings with the national focal points to impart more knowledge on their roles and to understand challenges and all that. So yes, we monitor the establishment of these national focal points. And there's a question on which sector or ministry should the national focal point be located. And I think that, again, as Ambrose mentioned, this is a choice of the country, but many of them have located the national focal point in the Ministry of Health because of the fact that a lot of the issues covered under IHR are related to health, but it should be in position also to conduct multi-sectoral coordination because there are many sectors that contribute to the improvement of IHR, to the implementation of IHR. Yes, Majud, please go ahead and answer that question you want to complement to. Maju, please.
Yes, just complementing, because the issue of the alternative, complementary and alternative medicine, just as has been mentioned, the CAM, complementary and alternative medicine, is not explicitly addressed in the international health regulation. However, it is indirectly addressed by the pandemic by the pandemic agreement, specifically Article 9, the research and development. So there is a room of having an innovation for health pandemic related health product and innovation and development. I think this can be addressed in further details during the upcoming webinar of pandemic agreement. Thank you so much.
Okay, thank you. There's a question on the
Miriam, I see a
IHR.
question.
Yes, please go ahead, Ambrose.
I see a question in the Q&A that will the National Health Authority not make NFP redundant? I don't know that, but I'll give you an example of, I mean, at the moment, really, when you look at it, the most NFPs have been in the Ministry of Health, and I think they have also been doing the additional function. I know countries that do like that. But I'll give you an example like Germany. Germany's national focal point for the IHR is the Ministry of Internal Affairs. But the implementation of the IHR, the monitoring and evaluation framework, and all the other things that are expanded are by the Robert Koch Institute. So I think that is the model that some people are looking at and say, if the NFP has these only few mandatory functions, if you don't explicitly, you can say we left it optional for the country to decide, but you have to designate who. So it was already there, but now it's really now that you have to designate and make sure that the National IHR Authority will complement, if it is not the host of the NFP, that they will work in complementarity with the NFP. I don't think it will make the NFP redundant because the roles are different and explicitly clarified in the IHR amendment. Over.
Okay. Many answers have been given in the Q&A chat. I don't know if people have problems with unmuting or putting up their hands. Mary, do you think it is the issue? Mary? Sorry, I am talking to Amarachi. Amarachi, do you guide people to how they put up their hands? You go to React. You go to React, and under React, there is raise hand. And you have 5 more minutes maximum, and we close this session. If no more questions, there are several questions that I thought were answered, but if you feel there's one that is not yet answered, please bring it to our attention. There's a question on the guideline for NIA, National IHR Authority. It is being finalized. It will be shared with the countries soon. So that one, expect
it was
it
actually shared on the 7th May. The draft.
It was a draft.
Yeah.
The final one will be shared in the near future.
Yeah.
And since the amended IHR is coming into force in the 19th of September, countries were really encouraged to think through the agency that they would designate as National IHR Authority and communicate to WHO preferably by then, so that now communication can start to be with the National IHR Authority. Yeah. Annually, questions are there. Yes, we send letters to the countries, national focal points, to update the contacts of their IHR focal points. But some people forget it, and we find that we are communicating with people who left the organization long ago. Please pay attention to updating these contacts annually. And the repercussions that countries don't adhere to IHR standards. I think that Ambrose mentioned that there is up to now no committee for monitoring that implementation or punishing, and that the repercussions, as Michael has responded there, are more diplomatic and reputational rather than punitive. And so it was out of moral obligation that every country is expected to adhere to the IHR regulations since they all endorsed this IHR obligation. In the amended IHRs, you will hear there's a committee being put up to monitor the implementation. Again, it will be monitoring and bringing it to the attention of non-adhering members. I don't know if there will be really a punitive action. It is more on the diplomatic and reputational issues. But that is the improvement that is happening. The monitoring committee, before it was also not present, and we saw the implications of that during COVID. Right? Okay. So as there are still no hands, we hope that we have answered as many questions as could. There was a question from Central African Republic. I think that this one is, we'll try to refer it to the team in WHO regional office that is responsible for that, and they should be able to come back to you about this.
Miriam, can Bukari summarize some of the questions that were in French?
I have been trying to summarize them through the Google translation.
Yeah.
It's just a few that may have not been answered, but Bukari will summarize those. Last comment, it is true that this will depend on the context of each country, that is about the national IHR authority. Can you give us examples of structures that can assume these two roles, authority as well as focal points? Will there be no conflict of interest or conflicts of competence?
I think for countries, for example, that have established national public health institutes, the role of the NFP would remain where it has been, probably mostly where it was, because that is really the contact reporting to the WHO contact person. But then if you look at some of those, the real implementation of the other issues would be really that then the implementation of the IHR, the monitoring and evaluation framework, the response to outbreaks. If you have set up a national public health institute, and within that maybe there is a public health emergency operations center, the coordination is already occurring within the NPHIs. So I see that countries with NPHIs might be quick to designate those, depending on their specificities, as their NIAs, and they could retain the reporting and the notification, because the issue around even assessment of the event is not an NFP function, but the NFP can support. But the assessment whether a function should be notified is done by a technical agency. So if it is a zoonotic event, you really need maybe zoonotic disease control units. If it's a health event, you need competencies within the ministries of health. So this is going to be on a case-by-case basis. And the complementary the document on how to do that, just like the NFP guide, will try to articulate that. But what would be required is then that somehow there must be a legislative, a policy framework to establish this. So it's a case by case basis, but I think there are examples where this could be very quickly fast tracked.
Okay. Winnie, if you go to raise the chat, it brings two lines. One is thanks and what, and then just below it, there's raise hand. So if people still want to raise a hand, 1 more minute. In the meantime, before I go to the next and closing, can I ask Mohammed to give final comments?
P3 in JEE.
Sure. So thank you so much, Dr. Miriam and Dr. Ambrosi, and thanks for the questions from all the colleagues. I think the topic that we discussed today was really important. The IHR in general, IHR amendments, the functionality of the national focal point, what is the new NIA or the National IHR Authority, and the IHR monitoring and evaluation framework. So from my side, in my presentation, I think the monitoring and evaluation of IHR is a very important step that all countries are required to do. Nowadays, even not only to know the gaps that you have in your capacities for implementation of IHR, but also for the resource mobilization. Resource mobilization is becoming very important, especially during the last 2 years almost. There is a scarcity of donors, and the whole world is shifting after COVID-19 is over. They are shifting from the health perspective. They are going to invest in other sectors, completely forgetting what happened during the COVID response. So the outcome of IHR monitoring and evaluation is very important to support the proposals with different donors, including pandemic fund and other funds. That's why I really appreciate the initiative from colleagues in AFRO to have such sessions to make people more aware about IHR amendments, monitoring and evaluation, and other topics. And from our side, we really appreciate this collaboration, and we are willing to continue it. And thanks for all the participants and attendees and for the questions. It was really a useful session. Thank you, and over to you, Dr.
Okay. Thank you, Mohammed. And any final comments, Ambrose?
No, I think it is. I have seen something on the JE, but I think that would really be. We will respond to that. I know that the JE version 3 try to address some of the things we have done implementing the first round of the JEEs. But to say that the IHR amendments are complementary to the pandemic agreement and they were targeted. So for me, it is the narrative that member states were almost thinking that they want to have reservations or rejection, because the amendments were targeted based on some of the failures on the gaps we saw in responding to COVID. So they are really meant to improve. And maybe the relationship between the NIA and the NFP will continue to do that, to send information. But I think reactivation also of the NFP networks so that NFPs can talk to each other will be important. So the dialogue with member states to make sure that the rationale for the NIA is understood, the elevation of it will be very critical for us moving forward and protecting our citizens. Over, please.
Okay, thank you very much. Now we go to the closing, the next steps and the closing. Before I go there, I would like to also acknowledge the support of colleagues who may not have talked during this session that have been very helpful in the organization of this response. I would like to acknowledge Dr. Gina Dukola, Dr. Jesse Bonwit, Dr. Alan Impeire, Dr. Bukare, the Chief Training Officer who has been leading these preparations, Dr. Ms. Pearl Kobuyenje, and then Dr. Michael who has talked. This is the team from AFRO, the team from EMRO, Dr. Amgad, who has given the opening remarks, Dr. Fatima, Dr. Maju, and Dr. Mohammed. Thank you very much. So now next steps. We have had a lot. I hope that this time we have tried to answer as many of your questions as possible on national IHR focal points and IHR, the principles, the roles, etc. If you need any more information, there are additional reading materials. And these on the screen are the links to additional materials that will give you more information on the IHR and IHR monitoring framework. If you find this, you can read through and you will be ready for the next session. We'll also share the recording and the presentations so that you are well prepared for the next session, which will be next week at 2 p.m. Please, we changed the timing from 11 to 2 p.m. because we got communication that for some countries, 11 a.m. was too early. To try and accommodate all, the meeting will be at 2 p.m. next week on Wednesday, the 6th. And we will cover the amendments and the domestication process. So please turn up in big numbers as today to listen and see how to domesticate the issues at the country level. Please go home with the message that IHR is to protect individuals, and these are real people, not just statistics. So it is important for us to try and implement these and comply to the policies, the provisions, the guidance, because it helps us to prevent, prepare for, and respond effectively to public health emergencies in a way that minimizes mortality and prevents transmission of diseases cross borders, prevents the socioeconomic interruptions as we saw with COVID. Lastly, we would invite you to complete the post-webinar survey so that we can get more feedback and insights from you on how to improve the future webinars and respond to your real needs. And with that, I want to thank all of you for coming. I want to thank all of you for participating in this seminar or webinar. And I thank all the facilitators for the work done in making sure it is a success. We come to the end of this meeting, and wish you all a lovely afternoon and evening. Bye.
Thank you so much. Bye-bye.
Bye.
Yeah.